Hello, and welcome to another webinar from HTA, presented by the Patient and Citizen Involvement Interest Group. This webinar has been developed by the HTA Interest Group for Patient and Citizen Involvement in HTA, PCIG, which brings together patients and citizens with staff from HTA bodies, government, research, industry, and consultancy to strengthen HTA with the systematic incorporation of patient and citizen perspectives. To submit any questions during the webinar, please use the Slido link that will be provided in the chat. A Q&A session will be facilitated during the final portion of the webinar. Thank you again for joining us. I will now hand things over to Eileen to formally welcome and introduce today's webinar.
Hi, everyone. Thank you for being here with us. We welcome everyone from different parts of the world. And I would like to, today we are going to talk about how patient involvement is making a difference in HTA. And we are going to present different perspectives of impact. So thank you everyone for being here with us. We will quickly review the preliminary findings of our project, the PCIG, and we have special guests who will share cases of impact from their different perspectives. So next slide, please. So my name is Aline Silva. I am a researcher from the University of Brasilia, Brazil, and University of British Columbia, Canada. I'm also a patient partner at the Patient Voices Network. And at the HTA PCIG, I am a steering committee member and also a co-lead of the PCIG Impact Project, which we will talk about later. So today with us, we also have my colleague, Veronica Lopez-Cussé. She is the co-lead of the Impact Project with me, and she also serves as the technical officer for the HTA's Patient Citizen Involvement Interest Group. Veronica is an independent consultant working with patient groups, pharmaceutical companies, HTA bodies to support patient-driven healthcare change. We also have Gustavo San Martin. He's here representing the patient perspective as the founder of the CDD, Crônicos do Dia a Dia, or Day by Day Chronic, and AMI, Amigos Múltiplos pela Esclerose, or Multiple Friends for Sclerosis. Sandra Pellai was invited to present the HTA agency perspective. She's a professional scientist from INES, the Institut Nacional d'Excellence en Santé et en Services Sociaux. And we also have, representing the industry perspective, Martin Combs from the UK. He is the Director of Policy, Advocacy and Government Affairs Manager at Bristol Myers Squibb. Martin is also a member of the HAI PCIG, and he co-leads one of its projects, which we will speak more about today. Next slide, please. So our webinar will follow this agenda. I will do some opening remarks. I will talk a little bit about our project, the Impact Project. I will also would like to getting to know a little bit more about you, our audience, and also about your perspectives. And I will give an overall view of our stakeholder perspectives of the impact of patient involvement in the HTA project. And then we have Veronica, who will explore some of our project findings, and we will move to our guests' perspectives on the impact of patient involvement in HTA. And then finally, we have a discussion where we would like to receive your questions. And please, next slide. And to do this, as Bryce mentioned, I'd like to ask you to join Slido. If you don't have it installed on your device, you can go to slido.com, enter the code that is here in the screen. And it would be great if you can focus all your questions and that you can focus the discussion here at Slido. Let's next slide, please. So to start to know more about our audience today, and we would like to know who is here today with us. So we would like to know what would you consider your main affiliation? Let's see how diverse is this audience today. That's great. We have HTA body, we have academics, industry, some patients, academia, HTA body, patient representatives. That's great. It's a very diverse audience. This is great, mainly because we are talking about different perspectives. It's changing all the time. Okay, it's good. I think we have a good view. We can go to the next slide. Also, we would like to know, in your opinion, how is patient involvement making a difference in HTA? So you can share with us. How do you think patient involvement is making a difference in health technology assessment, specifically? Here we are going to have word clouds. Let's see what is your perspective. That's great. Transparency, diversity, empowerment, unmet needs representation, real life experience. We have a lot of people saying transparency, empowerment. Some people are saying that it's patient involvement ensures patient access, broad view of the benefits. Great. It's great to see. So a lot of people are saying that it's empowerment, transparency, reality, right? Because patients, they bring what's really happening. That's great. I hope you can have this cloud later. You can have this to share with you later as well in our social media, etc. Okay, let's go to the next slide. Great, thank you. So as we could see, as you mentioned, we can see that the impacts, the outcomes of patient involvement, they can vary depending on the perspective, and it can also vary according to time. So we have shorter term, intermediate term, and longer term impacts. So in a shorter term, and first, I would like to acknowledge the Patient Voices Network who authorized the use of this slide. And it was part of a patient engagement learning series that I had the pleasure to attend in the last days. And it was like a coincidence because we were talking about this success and impact of patient engagement. And today, this week, we were talking about the impact again. So I asked them to share if I could use this slide. And it's very interesting to see that in a shorter term, we can raise empathy, awareness, we can build relationships, we can also have some difference, some change in decision-making process. Also in patient involvement in an intermediate term can influence in different initiatives, can influence decisions, the person and family-centered care, the healthcare care quality, and even health outcomes in an individual level. And in longer term, patient involvement can change the future of patient engagement in an organization, in a country. Patient experience, the staff experience can also change, can also be impacted by the patient involvement, and also the health outcomes in different populations. And we can also save, we can also have an impact in cost effectiveness. Next slide, please. So now I'm gonna give you a very quick overview about our project that we call Patient Impact Project. but it's the name, the complete name is Stakeholders Perspective of Impact of Patient Involvement in HTA. Please, next slide. And the objective, the goal of this research, this project, is to aid reflection on the impact and mechanisms of patient involvement using a questionnaire. So we have a template that captures the stories, different experience from different stakeholders. So we are gathering individuals' perspectives about how they perceive the patient involvement, what's the difference that the patient involvement has made in the specific HTAs, both to the HTA and to the individual. So currently we have 6 active members. I'm leading together with Veronica. We have Ana Toledo from Spain, and Singo from Australia, Ank from Switzerland, and Marcos from Brussels. And we would like to also thank, we are grateful for the past members of this project who led great knowledge, who shared great knowledge with us in the past. And unfortunately, due to other commitments, they could not remain in this project. Next slide, please. So this is the project timeline and some key deliverables. This project, it started with the methods and impact working group in the past, and also with these 2 papers. So these 2 papers, they were one of the first initiatives that started reflecting about impact in HTA, patient involvement impact in HTA. So it's the basis for the establishment of this project. So the first paper, Laura Wicks and colleagues scan what HTA bodies were doing to evaluate patient involvement in their processes. The second paper, Stories of Patient Involvement, results from a panel in 2017 in Rome. And here, Single put together patient involvement leaders, and we reflected and told some of patient impact stories. So in 2019, the Impact project was launched, initially led by Karen Facey, in collaboration with Single, Valentina, Samielo, Ank, and Heidi, when they pilot the version 2 of the templates that we have nowadays. So in 2020, the project name changed the name, so the name that we have today, and the template version 2 was updated and repilot. And then we have the template version 3, because there were updates alongside the project. We also created a guidance presentation to guide the participants that are telling their stories. And at the end of 2020, the project leadership was passed by Karen Facey to me, and also to Veronica. And at the beginning of 2021, last year, our efforts were focused on closing the final version of the template, the version 3, which is also now available online. And we also created a response tracker having the data analysis in mind. And last year, we also presented a panel endorsed by the CCIG, when we shared interesting examples regarding evaluation of patient involvement in HTA. So currently, this year, we continue to analyze the collected data, and we are also willing to have to collect more stories, more examples. And the main deliverables this year is currently this webinar is one of the main deliverables of this project. We also have HTA workshop in June that we are conducting in Utrecht, in Holland. And we also have a manuscript to be developed in the second semester. Next slide, please. You can press, yeah. So this is an overview of the template. So this is the survey structure. We have an introduction and background info from the person who is sharing with us the story about the impact. We have an informed consent, context question, and personal experience. You can press again, please. Yeah, and here it's describing how this experience, how was this impact, how patient involvement there, how they saw the involvement impacting or how they felt. So please, next slide. Yeah, so now Veronica is going to explore some of the themes of impact of patient involvement that we analyze with the results of this project using this template. Veronica, I pass to you.
Thank you, Aline. So as Aline just mentioned, my name is Veronica Lopez-Gusea, and I'm one of the co-leads of the Impact Project. So Aline just showed us the template, and what it's aimed to do is to capture different experiences of patient involvement in HTA and how it made a difference. So some of the questions, for example, are what would have been different if patients did not participate? What changed because patients participated? What would have been missed if patients didn't participate? And then we also ask about what could be improved because we know the process isn't perfect yet. So what I'm going to do today is I'm going to review some of the preliminary analysis of our findings so far. Because as Aline mentioned, one of the things that we want to deliver this year is a manuscript. So in terms of our findings, one of the very first and clear findings, just for lack of a better word, that our data showed us is that impact comes in various shapes and sizes. It's not just whether the final decision changed or not. So for example, we have the impact on the decision-making process itself. So what was the content of the discussion as well as the decision outcome? There's the impact of the patient stakeholders themselves. So what was their experience in the participation in the HTA process? Not so much the disease experience because that would be captured in the first bucket. And then for the HTA bodies, also what was the impact on their processes and their organizational culture? So what I'm going to do now is I'm going to review the different themes that we found through our data collection and the stories that we've gathered so far. And then we're going to make them come to life when we showcase a few of the examples that we've collected, who are the other three speakers we have with us today. So starting with the impact on decision-making bucket. So these are things that only the patient community can bring to the table. So for example, a non-diluted perspective of what it's like to live with the condition. What is the unmet needs in the community? What are some of the practicalities of taking the treatment? Would there be adherence to it if accepted, if reimbursed? What would be some of the financial implications for patients? There's also something that they can only provide is potentially an interpretation of the data that's different to someone who wouldn't live with the disease. Maybe a change in some outcome does not seem significant, but to someone living with the condition, that makes a huge difference in their day-to-day life. They can show limitations on the data. They can bring new data to the table, including on subpopulations, which often there's data missing on that. And then, of course, as we mentioned, there could be impact on the actual decision made. In terms of impact on the actual patient stakeholders, there is the feeling of being heard, of being part of the experience, of being able to make a difference in their own treatment course. Then as part of participation in the HTA process, if done correctly, then it will increase the patient community's understanding of the HTA process, of the thoughtfulness that goes into the decision-making, and then ideally also a better reception to the decision that's made at the end of the day. And with more participation and involvement, that then fosters other organizations to participate, other individuals to participate, and more people become involved. Similarly, on the HTA body side, one of the key impacts out of patient involvement is the ability for the HTA members to interact directly with patients and ask them questions about the data that they have in front of them. It also increases awareness of the importance of having patients participate in the HTA process, as they are the final consumer that's ultimately going to benefit. And then there's also a shift in perception from HTA looking at the patient community as someone that we just go ask a few questions and then retrieve it into our conference room, to someone that, or a community that we build a relationship, we build a partnership, we approach it together. And then lastly, as people see that it's making a difference, then the organizational culture again becomes more willingness to receive more patient participation and foster that as well. So as I mentioned, we also asked what could be improved. So that can be bucketed into these 3 different themes. So the first one being transparency and expectation setting. When you're going to have individuals from the patient community come and participate, they should know how long is it going to be? What is expected of them? Should they bring data with them? Is it slides? Are they just answering questions? It seems very basic, but through a lot of the stories that we've collected, it's crazy to see how many haven't even received this information before they participate. They show up not knowing what it's going to be like. And then also about the dialogue, is the HTA going to communicate with the patients after they provide a testimonial? What's that dialogue going to look like? In terms of training, there's of course training to the HTA body about the importance of involving patients, as well as training on how to appropriately engage with them and what is reasonable to ask a person living with the condition versus a patient representative, or maybe from a patient organization, and how is that completely different from what you would ask a healthcare provider, for example. And then on the flip side, also training for the patient community on how to effectively participate. So what is the purpose of HTA? What are the different steps? What is the evaluation criteria and so forth? And lastly, just related to systems and processes, making sure that the use of plain language is, as much as possible, that opportunities to participate in the HTA process are widely publicized, and that there's involvement of patients across the different stages and at different levels, even potentially at the organizational level at the HTA. And then also, as part of this work stream, especially, we need to advocate for this, for the systematic evaluation of the impact that patient involvement is making, so that then we can show the value of it to others as well. And so I think that brings me to the end of my my overview. So I'll hand it back to Aline, who's going to introduce our speakers. Thank you, Aline.
Thank you, Veronica. Thank you so much. Next slide, please. So to start with this sharing these different perspectives, we have Sandra Pelais, who will present the HTA body perspective. Please, Sandra, it's with you. Thank you.
So good morning, good afternoon, good evening. As mentioned, I'm a professional scientist at the INES, that is the Institut National d'Excellence en Santé et Services Sociaux, an HTA agency located in Quebec. The objective of this presentation is to share with you how patient and public involvement is ethically and methodologically implemented at the INES. Next slide, please. So broadly speaking, HTA is a multidimensional and multidisciplinary evaluation process to determine the value of a health-related technology, drug, or intervention. At the INES, we extend this evaluation to the social services as well. So now we're going to move into the interesting part. So why is it important to consider PPI, patient and public involvement, in the context of HTA? So according to our experience, patient involvement contributes to better portray the perspective of those who are dealing with a condition or disease. The insider's perspective help us to better not only to identify the challenges, unmet needs, struggles related to health-related treatments, but also other dimensions associated to the treatment. Like, for example, ethical issues, cost-benefit balance that patients do, or even the evaluation of the clinical outcomes from an insider perspective. So this said, patient and public participation allows us to have an invaluable value for HTA, because it allows us to see how patients perceive their treatment and how we can reflect that in the decisions we make. So this said, it is important to note that when we consider PPI in HTA, the decisions lead to a more fair, equitable, and legitimate decisions, democratic decisions, credible and transparent, and that are meaningful and relevant. So, this said, it is important to understand that patients have worked really very hard to raise the awareness of their conditions and diseases in the world. However, PPA in HTA is still a field under development. So next slide, please. So in this context, engaged too. I'm going to start sharing with you what is our mission. So our mission is to evaluate, as I mentioned, the technologies, the drugs, and the interventions. But it's important to understand that we are an independent agency, that we are at the same time committed to both clinical excellence as well as the efficient use of resources. So in this context, we are engaged to produce knowledge reports with or without recommendations, knowledge transfer tools and activities, and orientations for optimal implementation of innovations. Finally, we are committed to consider during the evaluation the clinical, populational, economic, organizational, and sociocultural dimensions, as well as the patients and the citizens' perspectives. Next slide, please. So how do we do that? So first of all, our framework is organized across 5 main principles. I'm not going to explain the principles in depth, but I'm just going to say that we start by considering whether we are able to evaluate an object, and we end up, if we decided to evaluate that object, we end up producing a report. So how does it happen? It happens through a period of time and resources that we take into account, and based on these resources that we have, and in the research question that is guiding our process, we decide how we include patients' perspectives. At the INES, we have 3 levels of participant involvement. One is consultation, that it means asking participants, and when I mean participants, I mean patients and public, about their perspective regarding a disease or a condition. We have collaboration, and it's when we invite these patients and public to take place and sit around a table and discuss a topic, and for example, maybe some guidelines. And we have the co-construction, that it's another level in which patients are involved since the very beginning of the process, and we build together some new products. But how does this happen? To make this happen, we provide support to the teams that are working with patients, okay? And this support is through trainings, through the offer of literature pertinent to the process, or even with some counseling and guidance. As well, we create some collaborations across the institution and even outside the institution, like, for example, with patient associations. And lately, we have created and launched 2 communities of practice. One is related to ethic issues, and the other one is related to methodological issues. Both of them are open to all the scientists that are within our institution, and they are open to discuss issues that come in the field. So they come to the communities of practice, and we discuss the issues. We try to find some new solutions, or we try to look for responses outside. Thank you. Next slide. So I'm going to share with you now one key case that for us was key because it was the first one to include co-construction at the INES. So this project was led by a colleague of us, Dr. Pomey, and we received a mandate from the Ministry of Health to assess the appropriateness of the clinical relevance or replacement of an ICD, that it's a tool, it's a device to prevent, that is used in primary prevention of malignant arrhythmia. So the objective was to consult, to mobilize the patient's knowledge, the experiential knowledge, and to come up with a co-constructed recommendations. To do this, we invited the participants that were patients that have been followed for cardiovascular diseases and that were benefiting from the replacement of ICDs. Okay, these patients participating, next slide, please. Oops. Another one. Okay, so these patients participated all across the process that was designed. So what were the main steps within this process? We have three main moments. One was to review the literature. That was done by the scientists at the INES, and the patients provided along with other participants in the process that were, for example, other scientists, clinicians, and even personnel from the INES. They reviewed the results from the lead review, and they provided their point of view. The second moment was to validate what was discussed in the review as well as in their own lives and experiences. So at this point in time, a Delphi process was conducted. So the main key parts of these discussions were taken into consideration. As you can see, the red arrows indicate where the patients have been included. And we have here at the time of the validation of the content that an expert clinician committee was working in parallel with the expert patient committee. And finally, after this discussion, we come up to create the recommendations. And again, at this point in time, the patient's experiences and voices were weighed in the same way that other participants that have been taking part of this process. Next slide, please. So I'm not going to explain this in detail just because of time constraints, because I know that this template is going to be shared. But what I would like to highlight, it was the first experience, as I mentioned before, in which we use co-construction, and we have been really attentive to all the patients' contributions. So, for example, we got the confirmation within all the process that their voices were listened as well as someone else's voices. We work a lot to include and to support the patients all across the process. And one of the things that we tried to work out as well during the process was in the sensibilization of all the participants to get to listen one to each other. So finally, we got the main impact of this intervention was that we got a co-constructed guidelines that for the first time in Quebec, it counted upon patients' participation. So what could be improved? It was some lessons to learn from this process, because as I mentioned before, it was our first experience. So first of all, we learned that we have to work a little bit harder to improve our recruitment strategies to have more diversified perspectives. So that was on one side. On the other hand, we learned that probably we need to be more sensitive to create some trustable links across participants and to get to listen one to each other and to trust in everyone's opinion and to learn how to contribute when we are contributing with different perspectives and we are discussing different perspectives. We understand as well as after we have reviewed the process that it is hard to understand someone else's perspective, and we need, especially when we are treating complex information. And the final learning lesson that we got from this exchange was that we need to keep on working on qualitative mix and participatory methods. But on the other hand, it was an excellent opportunity for all of us to launch this initiative at the INES and to keep on thinking about doing more initiatives that, as a matter of fact, followed. So next slide. So now, just we're very proud of what we have done so far, but we would like to keep on maintaining the right track. And for that, what are our future directions? So I said at the very beginning that this is a new field and there's a lot of work that is still needed. We are aware of that, and we are trying to develop all the tools, methods, and strategies to support this development, not only within our institution, but we're ready to share some of our experiences with our other agencies. So first of all, we want to build from our experiences, what we learn in this process and what we have to change in the future. We just created another venue that are reflective workshops to be implemented after the evaluations of some projects, just to see what we learn from the whole process. As well, we want to continue develop some material specifically tailored for HTA context and needs. We want to keep on working on diversifying the perspectives of the patients, and we have some patients that are participating in our processes at the INES, and that currently working on seeing how we can go further and capture more different perspectives and more points of view. We want to continue having meaningful engagement, meaning that, as I mentioned before, and it happens in this project, to give the value of the perspective of a patient the same value that we are going to give to the clinicians. So to work together to create new knowledge. We want to build bridges with other agencies in the field. So for example, what we are doing today, sharing our experience and learning from others. And we would like as well to seize the opportunity to enhance and facilitate PPA in our next coming endeavors. So thanks a lot. And I give the word to the following one.
Thank you so much, Sandra. It's always great to see the efforts from HTA agencies around the world, and you have been done great work, and it's very nice to see. And as I said, as you mentioned, it's always good to share this knowledge and learn from each other. Thank you very much. And now we have Gustavo San Martin. He's going to share the patient perspective. Gustavo, please take the stage.
Thank you, Aline. Good afternoon, good evening all. My name is Gustavo San Martin. I'm a multiple sclerosis patient. And in 2011, I started a patient organization here in Brazil to spread awareness and also to do some advocacy for multiple sclerosis. Aline, please, next slide. To put us all in the context of what are we going to talk about, my perspective here in Brazil, I'd like to give you an overview about how are we going to participate on a specific process of recommendation to disinvest in medicine here in Brazil. So as a patient group, we've worked almost 2 years with the society in order to change the first decision, which was to disinvest this technology. So I'm trying to reach you and talk about things that could be improved. For example, lack of transparency during the process of there is no official methodology to analyze the contributions, submissions, and also the lack of perceived value of public involvement during the process of HTA here in Brazil. So there is a confusion between social participation and also social pressure from the HTA board decision makers. Sometimes we just don't feel that they are perceiving the value of our participation and maybe just avoiding our participation during the whole process. Next slide, please, Aline. Some context of Brazil. Brazil has a full coverage by the public system. So we have SUS, universal covered, and we have CONITEC. CONITEC, below on the slide, is the National Committee for Technology Incorporation into SUS. CONITEC reports directly to SCTIE, is the Science, Technology and Strategic Inputs Secretary, who reports directly to the Ministry of Health. But we have some tricky points here. For example, the Ministry of Health and the health in Brazil is a kind of the most desirable place to be in a political way. So there is a lot of political influence. Just to let you know, in the 4 past years, we've had already 4 different ministers. So there is no plan in a long term of how to treat patients here in Brazil, because every year we are changing the Ministry of Health. But let's talk about CONITEC. CONITEC is structured by executive, secretary, and also plenary. The plenary has 30 members, 30 chairs. Only 1 chair of the 30 members are represented by patients or citizens. 1 is from medical society and 11 from the government. So just to put the perspective of the political influence and also the lack of a balance between society and government here in Brazil. But CONITEC is working to publish PCDT. We call PCDT clinical protocols and therapeutic guidelines. When CONITEC evaluate first this PCDT, they bring a first recommendation to the Science, Technology, and Strategy Secretary, SCT, who is responsible to take the final decision and publish the final decision. Next slide, please. What I would like to talk about is the process of HTA in CONITEC. So CONITEC normally receives a request of incorporation and evaluate all documentations. After that, CONITEC analyzed the studies and how strong they are, request additional studies if necessary. And then in red, you're gonna see the social participation here. So we have a plenary. When CONITEC asks for we call here in Brazil, witness patient. So they are gonna bring their voice, but just let you know, we have 220 million patients here in Brazil, and each patient from each region here in Brazil is totally different. But CONITEC pick 1 patient aleatory, and here patients are hearing patients during this process, just 10 minutes, like I have here to bring this message to you. So after that, CONITEC submits initial recommendation, as I said already, and open a public consultation to receive public comments. After that, CONITEC ratifies or rectifies recommendations and send to the SCTIE secretary, who can decide already, or maybe if he or she think that is necessary, can hold a public hearing. But we are going to talk about these public hearings in the next slide. After that, Secretary of SCTIE evaluates, report, decides, and publish his decision after 180 days after the decision already published. All the patients in Brazil who are using public system have the right to ask for this new treatment. Next slide, please, Aline. Okay, just a timeline about our case. In May 2015, we've had last multiple sclerosis PCDT publication. So it's newest at 2015, newest PCDT of multiple sclerosis. After 2 months, CONITEC, who were the same, who published the new PCDT, asked for a new proposal, a proposal of disinvestment of a drug who were at the 2015 May protocol. As part of the process, CONITEC asked to the society a public consultation, and we've run a massive communication campaign in order to bring the patient voice about this first disinvestment proposal on the history of CONITEC here in Brazil. was related to multiple sclerosis. So the multiple sclerosis society, their friends, family, parents, all of them made the second largest social participation in Brazil. And because of that, as I said, as I mentioned before, we request to the Secretary of HTA to conduct a public hearing, which is part of the process, the official process, but at that point had never been conducted already. In September of 2015, without any response, they present an official and public presentation, prescription of this technology, and we just didn't feel that was fair with patients, because some patients at that point could reach the technology, new patients couldn't. So the oldest could keep going with this their treatments, but newest no. So we ask for a public hearing on the Congress, on the legislative way. So Conitec requests more information during October, and we request the second public hearing, which is an official way to involve patients here in Brazil, but had never been conducted at that point. In 2016, July, there was a decision to restrict the medication. As I said, new patients could not reach the treatment, but old patients could keep having this treatment paid by SUS. Just after 2 years and almost a half, in 2017 November, the PCDT was updated and published with the same treatment that in July 2015, they wanted to exclude, to disinvest. So during this process, there wasn't any response from our questions, any response from the government, any response at all. But during 2 years and a half, we as patient group kept the communication, kept the provocation to discuss more about this proposal, which could affect different treatments for different disease after starting these disinvestment proposals in general. So next slide, please, Aline. What I wanted to bring is some results of our massive campaign. To put you in a context, more than 4,800 signatures. If it was diabetes, just comparing with the population who's suffering from diabetes here in Brazil, it could be almost 30 million people, persons with diabetes here in Brazil. So 4,000 MS contributions is like a lot, more than 15% of the all patients treated here in Brazil. More than 37 million people reached, more than 60 published articles on media, all the dimensions positives. Next slide, please. So what I want to bring to you is a rhetorical question about how social participation can be social pressure, but has to be just a pressure. As Sandra said, there is a good point between this contribution. Cannot just be like, oh, cannot be mandatory. We have to perceive the value, because we did the second largest participation in the history of public consultations. It was the first time that a final decision already published has been changed. The first time in history. During 10 years of existence, Conitec never held a public hearing until February 2021, when it called a public hearing to discuss incorporation of a rare disease. So we asked to the Minister of Health here last year, what were the criteria? Because in 2015, we requested 2 times for these public hearings, and we have had no response until now, 2022. But they respond. They said public outcry. That's how we evaluated the importance of bringing patients in a second place, like in a public hearing, to discuss a little bit more and to qualify the process of social participation. So I would ask you, should public outcry be the best criteria to involve patients in a so huge country and so different, so specific place like Brazil or South America or Europe or Latin America? I don't think so. There's no place who outcry can balance this participation. That's what I want to share and ask to you in a rhetorical way. Thank you, Aline.
Thank you, Gustavo. Thank you so much for your presentation. And it was a very provocative presentation, as I mentioned before. And I think it is good to do this. It's always good because it makes us to reflect, and the work that you have done, I'm pretty sure Conitec has learned a lot, not just only with your organization, but with the work that many other patient organizations have done in Brazil. And you stress how important it is to evaluate the impact, to evaluate the patient public involvement process, so we can systematize, we can have criteria and very transparent processes, right? So thank you so much for your presentation. And last but not least, we have Martin Combs, and he is going to share the industry perspective and a little bit of the project that he's co-leading at the PCIG. Thank you, Martin. It's with you.
Thank you, Eileen. It's a pleasure to join you. I think it's been clear from some of the discussion already that although understanding patient experience in decision-making around HTA is becoming widely recognized as being a critical part of HTA submissions, and greater efforts are being made to incorporate the experience into HTA. There's still a lot more that we can do, and it's interesting to see your project, Aline, and Veronica's project on the impact, and to understand that a little better. But it's clear that different countries are at different stages of this journey, so it's interesting to also learn from different countries as to how they're doing it and how we can learn from each other. I am quite lucky. I live in Scotland and work in Scotland, and the sun is shining. That doesn't always happen in Scotland, but equally I know that patient input is definitely helping to inform HTA decision making here. So I'm going to give you a quick example, if I may. So next slide, please, Veronica. So it is with the Scottish Medicines Consortium, and it relates to mesothelioma, which is a very difficult and challenging industrial cancer. It's asbestos-related lung cancer, very poor prognosis. So it has a very high unmet need and a severity of disease. For us as a company, we had a fair amount of uncertainty in some of the clinical data that we were submitting into the HTA, because although clinical trials are ongoing and we're still getting readouts on that data year on year, it's still not yet mature, and we still have lack of data in some of the subpopulations of this indication. So it's important that, you know, to say from an industry perspective, first of all, that we can't always just rely on clinical trial data. We have to make sure that we bring in patient experience and an impact on patients. And SMC, the Scottish Medicines Consortium, really does have an excellent engagement with patients and patient groups, and they bring that into the process at different stages, right at the beginning. So with a written patient group submission, during the appraisal, in meeting with patients and clinical experts in their patient and clinician engagement meeting, and also input to the decision-making committee, so attendance at the decision-making committee, so they can give their input to the decision at that point. So in this case, the input was provided by the main patient advocacy group, Mesothelioma UK, who also introduced patients that have been receiving treatment. And I think they were able to bring that experience into the SMC decision-making. I did raise with SMC, with Mesothelioma UK, that I was going to be mentioning this example tonight. And they sent me a message saying that their involvement really did give patient groups and charities like Mesothelioma UK a voice in the decision-making process. And they said it allows us to advocate for our patients by representing their views and describing the physical, mental, and emotional benefits of medicines, which may not otherwise be captured in conventional clinical and economic assessment process. So in this case, it did mean that SMC were able to take a flexible and pragmatic view and approve the indication earlier than we had expected, but importantly for us, for the full patient population. And that's been a challenge for us elsewhere. And I think the patient impact in this case was very useful for SMC to be able to give that approval. One thing, as you mentioned, Eileen, that I did want to mention was that SMC, as part of their support for patient engagement, had developed a plain language resource, information resource, which is the summary information for patients that is provided to patients and patient groups right at the start of the process to help them and help them be informed about the medicine that's being appraised, so that they can best give input to the different parts of the process. In terms of what could be improved, I think we're still working to see what aspects of the patient input into HTA decision making is really making an impact on how that decision is made. It's still, you know, that clarity still is not quite there. For us as an industry, I think having early engagement is really important. So it's not just about the patient and patient group input to the HTA body, but we as an industry need to get better at bringing it into our own HTA submissions and incorporating those patient experience into the evidence that we put into our submissions. However, the other thing that it's worth recognizing, and I work with a lot of patient advocacy groups and groups in the UK, there is a resource burden on them in terms of the time and effort it takes to do this. And I know that in many countries, patient groups providing input to HTA often aren't told about it and receive little or no information about the product that's being assessed. So that brings me on, if I may, to the HTA project that I'm co-leading alongside Kate Morgan from Myeloma Patients Europe. Thanks, Veronica. Next slide. Which is the project on the International Summary Information for Patient Groups template. As I mentioned, the approach began with SMC. And then where Kate Morgan and I first were involved with the development of a plain language resource, it was then picked up by the HTA Patients and Citizens Involvement Group to develop an international template and guidance that could be made available to other countries. It was piloted because, believe it or not, in England, NICE didn't have a similar resource. So it was piloted by us with NICE and also with the HTA body in Australia as well. So we now have a standardized template that can be used in other countries, and the project that Kate and I are co-leading is to try to encourage and support implementation and adoption in other countries. Next slide, please. So this is I guess, the summary of the project. Our aim, as it says, is to try and encourage broad adoption and adaptation, because we recognise that each process in different countries will be slightly different. But we see that the benefits will be for patient groups. There will be a relatively consistent information resource that will be tailored to address the information that they need around what the impacts are for the patients and the patient experience, and they can use that as a resource to inform their input to the HTA process. For industry, for us, it makes it much easier for us to make that kind of information available to all of our different affiliates around the globe. We put it into our global value dossiers, which is the information resource that each country pulls upon when they are developing their HTA submissions, and it just makes the whole process a lot easier. And for HTA bodies, I think, as well as allowing the patient advocacy groups and patients to have information that can support their input into the different processes that different HTA bodies undertake, it further encourages that patient engagement in the process. And I note on the right there all of the various colleagues that are involved in the project group across the different types of stakeholder, and appreciate all of their input, because it's quite a lot of work to raise awareness of this approach and get engagement in the various countries around the globe. And finally, just on the next slide, just to give you an idea of how it can fit in the process. Now, usually the company would submit to the HTA body with its HTA submission the summary information of the patient groups template requests specific information that is relevant to patient groups and to patients, is completed by the company and provided as part of the submission. It would be reviewed by the HTA body for appropriateness. If it's not up to scratch, then it can be sent back. But then the HTA body can make the plain language information resource available to patient groups, and that in turn can be used by the patient groups to input into the decision-making process. Obviously, that's a pretty simplistic view of things. And as I say, it can be adapted to suit the processes in different countries. So that's all I was going to say. Certainly, if anybody is interested in hearing more about the summary information for patient groups templates and how it can help, do please get in touch with us. Thank you very much.
Thank you so much, Martin. It was great to know a little bit more about your experiences, about this template that you helped to develop. And it's very, for me, it's always very important to stress to mention how industry is a strong ally on patient involvement, and how important it is to work with different stakeholders, to work together so we can have this different perspectives to co-construct, right? To collaborate and make things work better, for sure. So thank you so much for your time, and your presentation. It was excellent. And now we are going to our discussion. We have some time to discuss. You can have some questions. You can make extra questions. And here we already have some of the questions. If you have any more to talk, to mention, to ask to our speakers, here we have the first question was, someone mentioned that the template might be being burdensome for some parts because they have limited resources. So this person is asking, how can HTA bodies ensure a more inclusive approach? So I think this person is referring to the template I showed, right? So this template we showed is part of a project that is from the HAI, the society, the international society, and it's a project that we are trying to understand different perspectives. So it's not used by any HA agency, but I will leave this question, how can HA bodies ensure a more inclusive approach? Maybe one of the speakers would like to answer.
Yes, if I may, I would like to say that we are really concerned about that. So we are investing a lot of efforts to diversify the perspectives. But diversifying the perspective is not just saying, okay, we're going to take whoever it's knocking at the door. It's not just that. It's just being able to support the patients in the process of participation. So it's not just opening the door, but being friendly when people come to our agencies and want to participate. So it's being aware of their needs, of their the preferences, and to be able to listen to them. So it's a double effort of, helping to promote the calls for participation in the evaluation. That's one step. But the second step is to be able to friendly receive these people that wants to share their own experience. So it's a work to them, and it's a work within the institution. So this is something that we have in mind, and we are working hard to get that running in the way we want to have it. So it's not just diversifying or being more open to receive invitations. So it's just creating this environment for a proper interaction.
Great. Yeah, collaboration is so important for this. And another question is, could you share any thoughts on the differences between patient involvement inputs in HTA of interventions for prevention of disease or tests to healthy people? Someone would like to answer this question? Differences between patient involvement inputs and HTAs of interventions for prevention of disease or tests.
I guess I'm presuming that the question is relating to HTA around technologies versus, say, something like at the minute we're in the UK consulting on the introduction of targeted lung cancer screening. I'm presuming that that's the premise of the question. And I think my own experience in the UK is that the involvement of patients in and around HTA decision-making in the UK is much greater than the opportunity to co-construct some of the decision-making that occurs around decisions, say, for example, on screening. So there's things that could be learned from different parts of the system.
Great. Another question here to Martin. What type of evidence you include in your dossier submissions on patient perspectives? How to handle conflict of interest? This is a very good question.
Yeah, so in terms of the type of information, it does cover in the summary information with patient groups template, it covers what the medicine is, how it works, what the indication is, a summary of the clinical trial data, but most importantly, it covers it focuses on the impact on patients, around quality of life, around impact on carers, and also covers where are the greatest impacts on the health economics, the cost effectiveness, not in terms of you know, where the drivers are in terms of cost effectiveness. You know, what is actually driving the value of the medicine. As I said, the companies are completing that template, so it's important to recognize that there is a conflict. However, if you look at the guidance that we've prepared that goes alongside the template around the completion of it, it flags up very clearly what is expected, and also when it goes to SMC or at the moment to NICE, it's reviewed for fairness and balance. And if it's you know, just a story of how wonderful medicine is, it goes back to the company. And in answer to the next question, is it the same template that is come out of the NICE methods review? Yes, it is the one that's being incorporated into the NICE review.
A lot of interest, people in the field. Another person asked if are there any plans to try to have a broader adoption of the SIP globally? And
that's everything that our project is about, is trying to get greater awareness and to see how it could be adapted and adopted in different countries. We'd be very keen to speak with anybody who'd want to consider that, for sure.
Great. And you can find the template in the HTA PCIG page. We can share with you here in the chat, and we can share the website. Another question here is, what capabilities should patients develop to better participate in HTA? And I would like to have Gustavo answering this. What do you think, Gustavo? What capabilities should patients develop to better participate in HTA?
I think, first of all, patient has to be a patient, has to deal with their disease and their treatment, their collateral effects. This is important to bring to the discussion, but also as a patient who is participating on the HTA process here in Brazil, I think we have to know about the process, about the rules, about the way how it is being conducted, and how to reach the specific stakeholders with the perfect message. So, for example, maybe can be a tool to know how to tell your story. Maybe storytelling can be a good tool as well, because as a patient, you already know about yourself, about your life, but knowing about the rules, knowing about what kind of message could I deliver to different stakeholders can be a good way to achieve your point, which is bring the perspective of your own life, but also trying to represent different patients in a broad way.
Yeah, exactly. As Gustavo mentioned earlier, for example, in Brazil, at the HTA agency there, Conitec, patients now have 10 minutes, some patients, to present their perspective. They have this opportunity to give their testimonials. So they have 10 minutes to tell their story, to make their case. So yeah, I think training and like Gustavo mentioned, storytelling is a great method to achieve this for patients. It's a nice tool for patients to get involved, and they have the opportunity. And another question that I think maybe Gustavo can answer as well is, why is patient, not only Gustavo, but if anyone else would like to answer, why is patient input left so late in the process? Shouldn't it start at the beginning of the development? Seems too late to be meaningful once a product is market ready.
I would ask to Sandra to share her screen again, because she she showed a graphic, and I cannot bring my personal opinion here because maybe it can be too much patient opinion. But what I think is, as earlier involved, as more qualified the decision, the final decision. So I don't know why, but what do I know is what I do know. Sorry, is if it is in the final part of the procedure, you won't change what have been done before. So, for example, here in Brazil, when we ask for the witness patient to give their opinion, Conitec has already asked for a specific group of people to evaluate the technology and to bring their first opinion of that. So if you put in context their opinion are not related to the patient opinion because they already made their opinion about the treatment. So I don't know why, but what I do know is not helpful if you really want to involve patients. But I think Sandra have a good point on this as well, Sandra.
If I may, I thank you, Gustavo, for doing the first kick in saying what are the capabilities that we need from the patients. In addition to knowing the system, that this is a key thing, so what is the door that we need to knock, I could share 3 other capabilities that are important. So one, for me, it's the ability of communication, because you may know what you're going through, but probably it's hard for you to communicate what is going on. Especially in countries like Canada, where almost 50% of the populations are immigrants and do not speak their language matter. It's not either English or French. So communication is a broad theme, but it's one important thing to start with. A second one I could mention, that for me, it's trust, because if they don't feel trusted, if they feel that they are around the table sharing their opinions and they are the opinions are not being considered or they are not being taken seriously, so this can go against participation. And the last thing that I could say that it's important from a patient side, it's to be able to reflect on what they went through. It's like going a little bit beyond their own experience and sharing as well what they need. So it's hard when we are suffering a disease to compartmentalize ourselves and to say and to be aside of the suffering we're going through. But to participate properly, sometimes we need to make this parenthesis and being able to communicate, now what do I need? Okay, so that these are key things in my opinion, in addition to knowing the system, because knowing the system is key. We need to know which is the door that we need to knock. And Gustavo was saying why patients are coming late to the process. And I would say that resources is one of the things, the key things here, because in HTA, we have very limited times schedules. And to organize a patient participation, it takes time, because we need the time to contact the people and to make them feel comfortable, okay, and to build this trust. And this takes time. So if we keep on pushing just on doing speedy processes, we're probably going to miss this patient experience. But thanks, Gustavo, for bringing that up.
Yeah, it's great. It's great you mentioned this, knowing the system, Sandra, because in the YouTube chat, I saw Vanessa Pirolo. She mentioned this. She is a patient from Brazil as well. And she mentioned how important it is for the patients, for the society as well, to know the system and to know the process, how they can get involved, how they can participate. And here we have another very interesting question from Rosanna, from who? She said, selecting national health priorities, including the participation of patients, for example, maternal health, cancer, COVID-19 patients, comments. So from my understanding, she's selecting national health priorities, including participation of patients, and she would like some comments, suggestions. This is what I understood, Rosanna, but correct me if I didn't understand well. But if I may answer this, I think this session gave us a lot of great insights and about how it's important to have the patient involvement and the public involvement. So for selecting prioritization, this is one of the stages patients can be involved. And as we were talking, like since we were talking about earlier involvement, for example, in 2020, I finished my PhD, and I proposed to Brazil to have an earlier involvement and an involvement that goes through all the stages of the HTA. So since the prioritization. So I think we can think more about this and try to include patients. So we have different methodologies, consensus methods, and yeah. So if someone else would like to answer this as well. Okay, we have another question to Martin. Do you engage with parties prior to submission through surveys, panel discussion? Are the results part of your submission, even if not published?
It's a good question, and it is something that we're trying to get better at. And I think across the industry, we're trying to get better at incorporating patient experience into the submissions prior to them going in. And yes, that would involve things like panels and surveys. But I think, and that was part of my comment around, we need to engage earlier. And indeed, in the UK, NICE through the Office of Market Access and SMC is looking to do something similar, are looking to help try to provide that kind of safe harbor environment to be able to have some of those conversations, because we are a regulated industry, which means that we're tightly controlled in terms of what we can, how we can engage with the public ahead of marketing authorization license. But it definitely should happen and help to improve our submissions. I should also say, and even before that, and there's a note, the comment above there that says, patient involvement right at the beginning, it should be happening as well, so that it can inform the way that the clinical research is developed and shaped, because ultimately it needs to address what patients need at the end of it. And if there hasn't been that input to begin with, we won't necessarily get the right output. So both of those things, I think, are things the industry is trying to get better at.
That's great. Thank you so much. Thank you, Martin, for answering this.
Alina, I was just also going to say, this part of the discussion relates very well to the themes of the conference, the HTA conference in June. So everybody who wants to have an input in terms of how that shapes the life cycle around HTA, then do join that conference.
Yeah, great catch. Yeah, we are going to discuss the lifetime of the health technologies, and it's something that we are talking a lot within the PCIG. How important is the early engagement and even engagement in the P&D. So here in Canada, for example, we have the patient-oriented research. So we are involving patient partners since the beginning in the scope of the research, and they are part of the whole study. They are part of the research team. So it's some of these initiatives like this one I mentioned and others that we have here presented here. They are collaborating and going in this direction. Sandra, yeah, please, you have your hand.
Yes, I super agree with the early engagement, but we have to work hard to create a friendly environment. So what are the conditions that we are offering these patients to participate, especially when we are talking about, for example, mental health issues. So there are many things that may arise during a discussion. So what is the support and the counseling support, or like the strategies that we have in mind and in hand to support these people to get through the process as they should? Okay, because early engagement, it doesn't mean that we are inviting them to observe, we are inviting them to participate. So it's our job to go a little bit further and try to see what we can do to create this friendly environment.
Perfect, Sandra. I think we can go, we have only 4 minutes. We can try to answer this question later, or we are going to share our contact, but I think we should move forward because we will not have time to close our presentation, our session.
All right.
Can you go to the next slide? Yeah, great. So we need to tell you the next step. So we are going to now ask you to share your experiences with us. So we have our contact here. We have more context in the next slide. So if you have more questions, one question that we could not answer, I'm sorry. But we also, this project, the Impact Project, would like to receive more perspectives, to receive more stories about patient involvement and impact. So share your experiences with us. The template of the project, the Impact Project is in the PCIG website, and the sheet, the template that Martin shared with us, it's also there. We are going to share with you. Veronica, yeah, it's here. It's already here. This is the website, so HTA.org, and then we have the interest group, PCIG. There you can see many different projects that the patient citizen involvement group at the HTA is conducting. And we also invite you to join us in the annual meeting, HTA annual meeting in June. And we have a workshop and exploring methods for evaluating impact of patient public involvement in the assessment of the technologies along their life cycle. So exactly what we were talking about some minutes ago. And keep your eyes here. We have manuscript findings, manuscript publishing soon, being published soon. So stay connected. Next slide, please. Yeah, so here are our contacts, my contact here, Veronica, someone in the Slido asked for some papers. So I would be happy to share. And if you have any more comments, if you'd like to be more involved in the project, so please reach out. And I would like to thank you everyone for being here with us, mainly our guests who took the time to prepare the presentations with us. We met before. We would like to thank you so much for your time. It was a great job. You present excellent work. Yeah, you are doing so much effort. It's great. It was great to have you. I'm already receiving a lot of feedback here, and people really loved the session. I would also like to thank the HAI support that we are having here. We have Ivani, we have Naomi, Bryce, and thank you so much for all the communication to promote. They help us to promote the session, and it's going to be recorded on YouTube, so you can also later share with your network, and you can also go back to check some of the answers, some of the resources that were shared here. So thank you, everyone. Thank you for coming here, for being here with us. Thank you, Veronica. Thank you, Martin, Gustavo. Thank you, Sandra.
Thank
and
you.
See you soon.
Bye.
Bye, everyone. Thank you so much.
Thank you.